Okay, so the second part of this lecture, I'm picking up from slide 51, physiological calibrations. So your physiologic calibrations are also referred to as your biocals or biological calibrations. And essentially what they are is just a series of calibrations that we ask the patient to do some silly little exercises to test all the wires. Um, the exact things that we have the patient to do, the exact instructions and exercises can vary lab to lab, but for the most part, they're fairly standard, and it's just a test to make sure that everything's working correctly and as it should. So when we perform biocals is like right before we start the test, right before we mark lights out. So if the patient's we set them up and they're not ready for bed yet, we wait to do biocals until they're actually ready for bed. And so, how I usually explain it to the patients is if they're not ready for bed right when we're done with the electrode application, I just let them know that there's going to be about 10 minutes or so of calibrations that I've got to do with them, that some of it involves them where I talk to them through the intercom and just walk them through some silly little exercises, and then they can go ahead and try to fall asleep. So I always give them that little warning that, when you are ready for bed, let me know, but, make sure you give me about 10 minutes or so before you're really ready for bed, just so I can finish calibrating everything we need to calibrate for the study. The typical length of calibrations last around 5 minutes or so, but sometimes it can last a little longer depending if you got to do some troubleshooting. But the important thing with biocals is that they are so useful and helpful to help you troubleshoot what might be going on with your signals or with your electrode application. So if maybe you aren't that strong at troubleshooting things or recognizing artifacts, you know, like you've seen in some of the artifacts that we just covered, that impedances don't tell the whole story. So the biocals are that last fail safe for you to really check everything over and make sure that, if you tell the patient to snore and you don't see the snore kind of deflect on the snore channel, okay, you got something you got to go fix. So it really makes sure that everything's in working order, you know, as it should be. So make sure you pay attention to them. I can't tell you how many times I see you guys, not just you, but just even, some other texts in general, just, get through them to get through them and not use them for the kind of valuable kind of tool that it is. So biocals just really make sure everything's accurate. We have the patient go through some little exercises and make sure that everything's plugged in like it should and it's working like it should. And so the various instructions that we ask the patient are, this is a basic list of them. Again, some labs it might vary here and there. But eyes open, eyes closed. When we have them lie still with our eyes open, typically the instruction that I give to the patients is lie still with your eyes open, stare straight ahead, focus on a point on the ceiling until I tell you otherwise, and it's okay to blink. I don't tell them you're going to lie still for 30 seconds because I don't want them thinking, like, well, am I figuring out how long 30 seconds is? Are they going to tell me when? So I just tell them lie still with their eyes open and kind of leave it at that. I always make sure they know it's okay to blink, so they're not laying there with their like kind of keeping their eyes open. But the essential purpose of that one is to make sure, or just to get a baseline of what their brain waves look like when they're relaxed, awake, but their eyes are still open. The next one is to have them lie still with their eyes closed. Again, you're going to do that for a full epic or 30 seconds. And again, that's to get just a baseline of what their brain waves look like when they're relaxed and eyes closed. So these are the only two instructions that you let run for the full 30 seconds each. Beyond that, once you see a deflection and as you continue on, you can kind of move on. So biocals, I already said they're really helpful for troubleshooting, But one thing they're really useful for as well is when you're staging. So say your example, you're having trouble kind of differentiating this patient's wake from stage 1, you can use your biocals to refer back to, kind of be that baseline for the patient. Like, okay, this is when they were awake and their eyes were closed. This is when they were awake and their eyes were open. And then compare it to the epic that you're looking at that's in question to see, to really kind of flip back and forth between to see, are they awake or is it sleep? Because you've got that baseline that you can compare it to. The next set of instructions are to have them look up and down. So, how I usually frame it or phrase it is I'm going to have you open your eyes, and with your eyes only, don't move your head, look up and down. Um, and so you really just want to have them look up and down several times until you see that deflection. And I don't have them, I always make a point of saying don't move your head, because they will move their head. And instead of seeing them roll their eyes up and down, you'll just see the movement artifact of them moving their head. Same thing with having them look left and right. Have them do it a few times, but I always make sure they don't move their head at all. The next one, the blinking, blink 5 to 10 times. The clench the jaw, the grind their teeth. You want to make sure that you're going to see that deflection in the jaw, the EMG channel. All the respiratory instructions are to test all your respiratory channels, your flow signals, and your belts. The snore, cough, snore, is to test the integrity of your snore sensor to see if it's working. The next one is the legs. You're going to have them point and flex their left and their right foot. Sometimes in the systems, you'll see that it's listed as just flex feet. Instead of having them do both at the same time, have them do one and then the other so it's very clear what you're seeing. And then the last one is paradoxical breathing, which is, having them hold their breath. And then this is a silly one. It's always hard to explain. And it's hard for the patients to understand too. But what you tell them to do is take a deep breath in, hold your breath, and while you're holding your breath, I want you to push your stomach in and out several times and try to wiggle those belts that are going across your chest and belly. And it's another way to test your respiratory signals. So let's take a look at what they all look like. This is an example of having the patient lie awake with their eyes open. You can see the little tag on the bottom because you mark when you told them to do it, so it's tagged within the study. So here they are awake with their eyes open, and this tech only let it run for about 20 seconds before they had them close their eyes. But what we can see in these 20 seconds is just a baseline of their brain waves when they're relaxed, awake, eyes open. You can see these little blips here. 1, 2, 3, 4. That's them blinking, all these little blinks. And then when you had them close their eyes, you see them kind of flip over, and then you'll see it kind of flatten out with them being relaxed with their eyes closed. So here's an example of eyes closed. Again, let it run for the full epic, just so you can really get a good sampling of what their brain waves look like when they're awake, relaxed, but with their eyes closed. And you can see that kind of dip in their eyes that deflection when they close their eyes. And the hope is that you might start to see, what their alpha might look like if they have alpha, and you'll really see that more pronounced in your occipital channels. The next one are the eye exercises where you have them. This is one where you have them look up and down, up and down, up and down. You don't need to make them do this for a full 30 seconds. Once you see that have a few deflections, you can move on. Once you see what you want to see, you don't need to make them do it for the full 30 seconds, but that's the eyes up and down. This is where they told them to move their eyes left and right. When you have a patient look left and right, the response is pretty much the same in every patient. You see the eyes kind of crisscross like that versus when you have them look up and down. This might look a little different patient to patient. Interestingly enough, you'll see it on the next slide too. It'll look a little bit different with the next patient. But once you see what you want to see, move on. And then this is where they had them blink their eyes. This patient was a pretty fast blinker. We got a bunch of blinks right all in a row there. Some patients blink a little bit slower, and that's all right. What I usually tell them to do is just blink their eyes 5 to 10 times, and then once they're Once I see what I need to see, we move on. Here's an example again, eyes up and down. So this patient, it wasn't as dramatic having them move their eyes up and down. And if I probably would have had them do this for a little bit longer just so I could get a better sampling of what that looked like when they looked up and down. But here they had the patient look left and right, and they only had them do it twice, look left, look right. But the crisscrossing is the same when you have a person look left and right. This is their eye blinks. You got a bunch of them in a row. This person's a quick blinker. So the eye exercises you can move through pretty quickly. Another example. Eyes up and down. Kind of almost looks like blinks in this person. And then you get a little bit more of the rolling. You got them looking left and right. And then bunches of blinks right in there. The grind their teeth, clench their jaw. You'll see it sometimes written out a few different ways or written out a bunch of different ways. I generally start with one command. Just, try to grind your teeth or clench your jaw. And then just look to see if you see this deflection in your EMG channel where it goes up after, when you tell them to do that. Sometimes it doesn't, depending on the way that they are following your command, where you might have your EMG electrodes on, how they're responding, like if they're truly activating the masseter muscle or if they're activating a different set of muscles. So instead of hitting them with like 3 different things, okay, clench your jaw, grind your teeth, and swallow, I'll start with one. If that doesn't work, I'll try the next. All right, why don't you try grinding your teeth now? Okay, can you give me a swallow? Can you do a good swallow? And one of those, you'll see this deflection start to come up. Don't hit them with all 3 at once because they don't even know what to do. You want me to clench my jaw, grind my teeth, and swallow? That's a lot to follow. Another example of it, just a little deflection here. When you ask them to do something, they did it, and you see that deflection. So this in all likelihood is probably they just had them like swallow or something, and you see that kind of blip in the muscle activation. But that's all we really need to see. You don't need to spend a ton of time or see a huge deflection. As long as you see this deflection, you ask the patient to do something, they did it, and you see that response on your computer screen, then you can move on. This is an example of just having the patient breathe through their nose. Basically, I let this generally run a little bit longer than the last few exercises because you want to make sure you let them breathe a few breaths and see the difference. You make sure your respiratory channels are all in sync with each other, meaning they're all going in the same direction at the same time. Then you can see here the little spot where they told them to start breathing through their mouth. You typically do see their chin come up too at that point when they open up their mouth. Sometimes, interestingly enough, you'll see a person's chin tone go down when they open up their mouth, depending on how they have their mouth opened or closed. When you have the patient breathe through their mouth only, what you're looking for is to ensure that your respiratory channels continue to move. And what that means is all of our little flow channels, like our thermal sensor, has that little piece that hangs in front of the patient's mouth. And so that's intended for if the patient were to start breathing through their mouth at night, we'll still be able to pick up their breathing regardless of how they breathe, through their nose or through their mouth. So during the biocals, if you tell them to breathe through their mouth and then the signal flatlines, you need to go in and adjust where those pieces are to make sure that they're going to pick up the patient's breathing if they were to breathe through their mouth. So for an example of that, if you look at your nasal pressure signal, see how it pretty much flatlines? It's that little black line here when the patient's breathing through their mouth. Now, if this was the type of cannula that had the mouthpiece, I would go in, I'd adjust it, I'd maybe trim it up a little bit or something to make sure it's going to pick up their breathing. If this is the type of nasal pressure cannula that I have on, it's only the nasal component, well, I'm not going to really see much in the mouth. I'm going to move on. Here we have the patient hold their breath for at least 10 seconds. holding their breath, just kind of again test the respiratory channels, and it mimics a respiratory event. So you have no airflow for at least 10 seconds. No airflow means apnea. And then to determine the type of apnea, you look at what's happening in the respiratory effort. So when you have a person hold their breath, there's no movement in your belts. There's no, which means equates to no effort. So this would mean a central apnea. That's what a central apnea looks like. It's not truly a central apnea because we're asking the patient to do it, but just so you can see what an apnea would look like on the actual recording system. The pointing the legs. So you want to have them point their left foot and their right foot. You want to look for the, again, just like with the chin, you want to see the deflection in the muscle channel. I always ask them to do it separately, not at the same time, because if you had them flex their feet at the same time, they would kind of obscure each other and you wouldn't even be able to tell the difference between one or the other. And then I also pay attention. I'm the one telling them. I don't say just flex one foot, okay, flex the other. I tell them what foot I want to see flexed. Flex your left foot. That way I can see, is the left foot, the left leg channel, the one being activated? If it's not, say I tell them to flex their left foot and I see the right leg channel activated, one of two things is happening. Either they don't know their left from the right, or I switched my wires, plugging them into the head box. What you can do for this is look at the camera. As the person's flexing their foot, which foot do you see getting flexed? Did they have it switched, or did I switch my wires? And the reason why that's important is because if one of the leg leads comes off on my signal or on my screen, it's looking like it's the left leg. I go in, wake the patient up, I'm sitting there trying to fix it, but it's actually their other leg. Well, I've just needlessly woken them up and I'm taking even longer in the room than I should be. And when we do go in to fix something in the middle of the night, you want to try to really minimize the time you're in and make sure that you're fixing the one that you need to be fixing. So that's where I have them just flex your left leg, okay, flex your right leg. And sometimes, patients don't always fully understand. Like, I'm not going to say, okay, flex your foot. I tell them, okay, point and flex your foot at the ankle, like you're stepping on a gas pedal, just so they know to, like, point, flex to really activate that muscle. On the other end of this epic is where the tech moved on to having them do some snoring. So again, usually I start off with, give me a fake snore. I want to hear like a true representation of how this channel will show when they snore. Some patients get a little embarrassed by that, or they don't do anything so great that it really comes through. So you can have them either cough or count to 3. But you want to make sure that what you're hearing is coming through on the severity of the snore signal. And what I mean by that is, on this next example, you had them snore and we don't have as big of a deflection as the previous slide. And that's okay. But if I told the patient to snore and I'm hearing some really big loud sounds and I'm only seeing little blips like that, well, I probably want to go in and adjust where my snore sensor is to make sure that it's in place, that it's going to pick up the sounds accurately. Because if you're telling the patient to snore pretty loud and you're hearing them through the intercom really loud and this is what you're hearing, that lines up. But if I'm hearing something really loud and I'm only seeing like a small little blip, okay, let's go adjust it. Or if you're hearing a medium sound, let's run medium-sized snore. Make sure it lines up. Here's an example of having the patient perform paradoxical breathing. So again, this is that little funny one where we have them lie still. This is how we tell the patients, lie still, hold your breath, and while you're holding your breath, push your belly in and out to try to wiggle those belts that are going across the chest and the abdomen. And so this one tests the respiratory channels, and it also will mimic a specific respiratory event. And so again, a breath hold, you have a flat line on your respiratory channel, no flow, so that means apnea. When you look at the respiratory effort, that's how you can determine the type of apnea. So there's continued effort here. That means it's imitating an obstructive apnea. So paradoxical breathing means that the chest and the abdomen are in paradox, or in opposition or opposite to each other. Normal breathing, our chest and abdomen are in sync with each other, and you can see that in the rest of the epic, their chest and their abdomen are in sync, but here they're out of sync. Typical in a patient that's having an obstructive apnea. So the thing with BioCals is don't rush it. It takes on average about 5 minutes, but if you're having trouble with things, if you've got to make adjustments, it can take as long as 10 minutes, 15 minutes, whatever. Make sure you take the time to actually look at the signals. If you're putting your patient through all this, use it. Use it for what it's worth, and really look at your signals to help guide you in what you might want to fix, in picking up anything that's not working like it should. It's very helpful and a very useful tool. So we're just going to lastly just going to go through and review how to correct some artifacts. You know, ideally, you want to make sure that your application is as good of a quality as possible, and from the get-go, and make sure it's good to go at the beginning of the night. But once the patient is asleep, we really do want to be very careful with waking the patient up, if at all possible, and we can digitally correct some of these artifacts. That's more the optimal method, until the patient wakes up on their own. Like, say they get up to the bathroom break, okay, then I'm going to jump in and fix some of these wires. So if you have an electrode that popped off, if possible, we try to re-reference. An example of that is, like, for instance, say M1 popped off or isn't reading well. Well, let's reference everything else to M2 for now. If one of my chin leads pop off, we have 3 of them, use the other 2, re-reference your channels so that you're looking at the other 2. If one of my leg leads popped off, let's say left leg 2 popped off, instead of going in and fixing it, I would probably re-reference left leg 1 to one of the right leg lead channels to just kind of at least continue on with the study without waking the patient up. If an artifact appears in 3 channels and they all have a common reference, well, the likelihood that the bad channel or the bad signal is coming from all 3 of those channels is low. It's in all likelihood coming from whatever the common reference channel is. So you want to go in and either fix the common reference channel, or if possible, re-reference that reference channel. So again, that would be like switching from M1 to your M2, that type of thing, instead of fixing. It's not going to be all your C3 and C3 F3 O1 that are referenced to M2. It'll be whatever the common reference is. If you have a poor signal pop up in a single EEG channel, and even though it shares a reference electrode with other channels, if the other channels look okay or look good, then it's not the reference electrode, it's the actual EEG channel. And if possible, we'll look at something else. So we're running off of 6 EEG channels. If one of the channels pop off, well, we've got 5 other ones we can go on. We're not going to go in and wake the patient up to fix a single EEG channel. And in all seriousness, or in the reality, we can actually run a EEG or a sleep study off of just 3 EEG channels. So, like, this is more when you have kids and they're flipping and flopping, pulling everything. Sometimes you are down to a few channels, and as long as you have at least 3 channels, and then you kind of just keep on going and go in to fix when absolutely necessary. If their artifact appears or you lose a signal and you don't have a backup electrode, you really have to weigh the importance of the electrode itself, the missing channel, and the interruption to the patient's sleep study, the interruption to their sleep, because we really want to try to record their sleep. If we're going in and fixing something every 20 minutes, then we're not getting an accurate representation of what their sleep is. So you really want to weigh the importance of it. Now, that being said, there's a few channels that we absolutely cannot go without. That would be your EKG and your saturation, your SpO2 probe. If that comes off, you are 100% going in and waking the patient up to fix it, because that's patient safety. We need to make sure we have that recorded and it's, accurate, and it's a good channel coming through, because if it isn't, then that could be your patient's life, that you're just not even recognizing that it's not going well. If a low frequency artifact appears, in all likelihood, it's going to be sweat artifact. The patient is sweating. So what you're going to want to do is cool the patient. If necessary, temporarily raise your low frequency filter to digitally correct it. But it's temporary. So once the room is cooled down, or if it's a hot flash, once the hot flash has subsided, bring your filters back to kind of factory reset, so to speak, so you're really looking at everything the way you should be. You don't want to leave something overly filtered, because that can obscure what you're looking at. Again, double referencing is only beneficial to reduce EKG artifact in your EEG or EOG channels. What double referencing does is it will kind of reduce any common signals coming through in both electrodes, both M1 and M2. So if EKG artifact is getting picked up in both M1 and M2, it'll wipe it out. But it's only beneficial to decrease EKG artifact for your EOGs and your EEG channels. It doesn't do anything for sweat or 60 hertz artifact or anything like that. And I think this is the fourth time I've said that, so it's probably pretty important. When you have an artifact, really try not to change your filters. Sometimes it's necessary. I get it. It is. But it's really only effective as long as your underlying signals are intact. So like, for instance, if the patient's sweating, but our electrodes itself, they're still on, they're still recording pretty well, by raising the low frequency filter, it will correct the artifact, and we still will get a decent signal. But if it's, because the electrode's almost falling off or slipping off, the patient's sweating so much, well, then you need to go in and fix it. But changing your filters is a last resort. You really want to make sure that you've exhausted all other things before changing and messing around with your filters. So let's review some of the artifacts that we reviewed today. What you're looking at is 60 hertz artifact. So it comes through, 60 hertz artifact is an electrical interference, and it comes through as causing a signal to be thicker. Because again, it's so fast what you're seeing, this up-down oscillation of this artifact coming through, that it just comes through as more of a thicker channel. And when it's really bad, it can really obscure what you're looking at. So the number one cause of it is electrode application. Go in, re-prep, refix the electrode, make sure that you scrubbed well enough. The other number one cause is unequal impedances. So if you don't have your impedances equal, they're going to also cause this disparity in your channel and cause that 60 hertz interference. This artifact, EKG, we see a lot of spikes happening throughout, and it lines up right with your EKG channel. So for your EEG and EOG channels, what you can do is double reference, because M1, M2 are the common reference here, And if we combine the signals from M1, M2, it'll eliminate the like signal of the EKG artifact coming through. But ideally, you would recognize this when you first plug the patient in to check your impedances, because the impedances don't tell the whole story. When you plug a patient in, your impedances could be really great, and then you still got to look at your channels and look at your display to see the quality of your signals, and that's where you would see then the EKG artifact coming through, and you could move your M's at that point, move your M1, M2, make sure they're really on that bone and not in any soft tissue behind the ear, to try to eliminate that artifact at its source. The EKG artifact that's happening in the EMG channel. So, EKG artifact in an EMG channel is always due to poor electrode placement. In all likelihood, the EMG was just placed too far apart, and so it's picking up the kind of pulse beat because it's got more body tissue to travel through in order to reference to each other. So EKG artifact in a muscle channel is always due to poor electrode placement. And if it was worse, this one you can pretty much read through it. But if it was worse, you would have to go in and move your EMG channels. And again, this is just points the more story of the importance of looking at your signals and not just relying on impedance levels to figure out the quality of your signals. Movement. We got a lot of movement going on here. You're not going to really be able to read much of anything, but luckily once a patient falls asleep or once they stop moving, it'll settle down. Patients, everyone, we're allowed to get comfortable. We're allowed to move. We're not going to ask our patients to not move. Once it settles down, if they knocked anything off, that'll become apparent if you got to go in and fix something. But otherwise, you just kind of let it take its course, let them stop wriggling and moving, and this will settle itself down. So in this slide, this actually isn't an artifact, it's a seizure. I threw this in here because I wanted to highlight how easy it is for something serious to come through and look potentially like an artifact. This happens in our EKG channel too. Like, you can see artifact and it looks like a pretty serious arrhythmia, or vice versa. So you could have something that you think is an artifact and it's actually something pretty serious, like a seizure that you see here. So that's why I just wanted to point out how important it is to make sure that your signals and your application is as secure and as high quality as possible in order to make sure that the signals that we see, we can trust that they are validated signals going on. And then you would be able to see, like, wow, this patient just had a seizure. I should probably figure out what I need to do for my lab protocol, what the lab wants me to do if this patient just had a nocturnal seizure. This artifact is pen blocking. You know it because of the squaring off happening in the channel. Because it's happening in my EEGs, in all likelihood it's due to sweat artifacts. So I never want to mess around with the height of my EEG channel. So instead of playing around with that, what I would do instead is try to cool the patient to minimize what's causing the pen blocking, to correct it at its source. Versus, if I saw it in a different channel, then you would want to decrease the channel gain or the height of the channel so that it will fully deflect within its channel parameters. This is an example of electrode popping. It's a version of, or a form of, 60 hertz interference. So you would treat it just like you would any other 60 hertz interference, in that you want to make sure your electrode application is decent. your impedances are equal. What causes this, you see it most in the legs, and usually what causes it is if the EKG stickers get dried out or there's tension on the wires. Say the patient moved around a lot and the leg wires got a little tight with it underneath through their PJs. So going in and giving them more slack on the legs. But if you look at this, it's, one little blip. It's not going to interfere with you being able to read what's happening in the rest of the channels. It's not worth going in and waking the patient up to fix this. If it was happening a lot and it interfered with the integrity of being able to actually see what's going on, then yes, you would need to go in and fix it. This, what you're looking at, this kind of lollygagging slow wave, that's sweat artifact. Patient's sweating. We know it's sweat because it doesn't line up with what's happening in the other sets of channels. It's just kind of they're doing on its own thing. You see a lot of just sway and sweat going on. So go in, cool the patient off, lower the thermostat, take off the extra blanket, turn a fan on. If absolutely necessary, you can raise your low frequency filter up for temporarily in order to kind of block out this slow wave artifact coming through. All right, so here's an example that's taken out of one of the studies we've got on Sandman that you guys can review. So let's first look at what biocals are being done. So this one says teeth grind, yawn, swallow. So we had the patient grind their teeth. We saw the deflection. That looks good. This is having the patient take a big breath in and out. All the channels are moving. This is where they had them hold their breath, and you can see it flatline, so that worked. But what adjustment we would want to make based on the instructions given to the patient is, if you look at your respiratory channels, one thing I noticed is when they had the patient do their normal take a big breath in, they weren't all going in the same direction. One's opposite each other of the rest, and that's your airflow channel, the green one. See how it's going in opposition or opposite to the other channels? You want to make sure all your respiratory channels are in sync with each other at the start of the test. So you would want to flip the polarity of this channel, and you can do it digitally. You don't have to go in and do anything in the patient's room. It's basically just flipping the channel over so that it's in sync with everything else. All right, so the BioCal. What I see is you have this flat line in their breathing, but then you have these movements in their respiratory effort. And so that is paradoxical breathing, and it's mimicking an obstructive apnea where you have no flow for at least 10 seconds and continued movement or representing effort in your chest and abdominal belts. So the artifact, there's actually a decent amount of artifacts we can talk about here. So let's jump up to your EEG. If you look at your EEG channels, which are the top 6, one looks different than all the rest, and that is your F3. F3 is a lot thicker than the rest, so that's some 60 hertz artifact going on. I would want to go in, troubleshoot, either re-prep, reapply, re-clean the electrode itself. Might be a dirty electrode, especially when everything else looks super clean. You scrubbed well, you had a good technique, and one is off. It could be a dirty electrode. What else do we see? Come down here, you look at your leg channels. In this leg, left leg is the top one, right leg is the bottom one. Right leg looks beautiful. It's thin, there's no artifact in it. You look at your left leg and it's thicker, which shows 60 hertz, and you have EKG artifact. You have all these spikes. Remember, anytime you have EKG artifact in an EMG or a muscle channel, it's because of poor electrode placement. So probably what happened was these electrodes were either placed too far apart, they have too much distance between them that they have to ping off of each other in order to pick up the signal, or maybe the electrodes were placed too far away from the muscle. So if you go too far out on the leg, you'll start to see more of this artifact coming in because it has to ping through more body matter in order to get to the muscle that it's trying to record from. Either way, you'd want to go in and fix it at its source to try to correct that artifact happening, especially when you know you can get a decent signal. You show that the person got it on the right leg. Well, what happened with the left leg that they weren't able to get a decent signal as well? All right, so let's look at what's happening. So first let's do a biocal. This could be patients awake, eyes open, because you just kind of have about 30 seconds resting of their eyes open. They are blinking here, blink, 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 blink. But I also look down and look in their respiratory, and I see, in all likelihood, it's breath hold, because there's just a flat line of their respiratory effort, a flat line of their breathing and everything. So this is in all likelihood the tech telling the patient to hold their breath, since we see a flat line and everything. But artifacts, a few artifacts in here. Got some pen blocking in your C3, C4, O1 channel, your third one down, some pen blocking here. We also have pen blocking in your chest belt. So what you'd want to do is decrease the gain or decrease the height of this channel, or the height of the signal, so that it's fully able to deflect within the channel so you can see it fully. I never want to change the height of my EEGs. In all likelihood, when you see pen blocking, it's because of sweat. And it probably is sweat, because if you come here and look down in your EKG, you see how there's some bouncing in the channel. It's slight, but it's there. There's this little bouncing, whereas most EKG channels are pretty straight. And so the fact that this is already starting to bounce, this patient's sweating. I'd probably go in and make sure the thermostat was as low as I could possibly turn it at the start of the study, in order to make sure, because this patient's already sweating. It's only going to get worse once they fall asleep. Here's an example of, so there's a lot going on here, but the biocal that I see is paradoxical breathing. So no airflow, but this kind of paradoxical, it's a very distinct looking waveform that you see in the respiratory effort. So that's what they're asking them to do, is just hold their breath and push their belly in and out, to wiggle those belts. But the artifacts, so we got a lot of ugliness up here in the EEGs. You've got squaring, pen blocking, you've got this really thickness going on, which could be 60 hertz. There's nastiness in the EKG, which is probably a lot of them moving and everything. Artifact. So with all like the ugliness in this epic, I would probably in this instance wait for the patient to fall asleep, because this could also be just muscle artifact. Muscle that if they're really tense, it can come through and look kind of like 60 hertz. You just want to give them a minute or two. Let them relax and see if it goes away. The thing that won't fix itself on its own is this EKG artifact happening in your EEGs and EOGs. And so if I were to go in the room to fix it, I'd probably actually start with my M1 and not M2, and see if that corrects it, because it looks like it's actually worse on one side over the other. Like it's worse in all the channels that are referenced to M1 than the channels that are referenced to M2, where it becomes really obvious, like right here. Look right here. C3 to M2 is this top channel, and you get a little bit of EKG artifact, yes, but C4 to M1, you really see the spikes here. And then I know these channels kind of start bleeding into each other, but all the ones that are referenced to M1 is where you really see these spikes. So I'd probably go in and start by just trying to move where my M1 is placed, because it might have slid down in the process of after setting the patient up, whatever they did after that. Who knows? It might have slid a little bit and started picking up some of that EKG artifact. The thing that I don't like is how you lose your EKG signal when the patient kicks and moves. You see, when they're kicking here, again, it really obscures it. So this is such an important channel. I would probably go in and just make sure that my signal is at as good a contact as possible, because it doesn't matter how much the patient's moving. You know, you see all these other examples. It gets a little ugly when they are kicking here, but you're really losing the signal here with every little bit of kicks, and you want to make sure that this channel is as stable as possible, because it's patient safety. This last example is a patient chewing. So with every bite they take, you see this massive amount of just muscle artifact coming through in all your EEGs. Luckily, we don't see this very often, because hopefully patients come to fall asleep, not to sit there and eat in bed. But sometimes you will see it, so it's something to be mindful of, to watch for. Like if you have a patient, either they, trying to lay there with gum in their mouth, or trying to sneak a snack and they didn't tell you. It's one of those things that once they stop eating, it goes away, but you just got to document it's happening and that it's there, and it can cause a lot of ugliness. So that's all I got. Keep practicing. The more you get hands-on with artifacts and trying to pinpoint what you're looking at, the better you'll be at it. It's one thing to sit here and listen to me, but once you've done it yourself, it's something for you to commit to your memory and commit to your experience that you have, that you'll have a lot better of a grasp on it. So really try to do whatever you can to get your hands on the staging end of it, staging the studies in the sleep lab and the application, and practice going through the biocals and start looking beyond the impedance levels, because that's only part of the story. But I'm here if you have any questions, so make comments on through here and I'll see it, or through, if you have any other questions, you can email me or do the Ask the Professor discussion board that I added to Blackboard. And talk to you soon.